Well, hello, friends. And we're just excited today because today is another day with Kidney Talks with the Ron and Joy Paul Kidney Center from the George Washington University. I am your host, Reverend Dr. Kendrick Curry of the Pennsylvania Avenue Baptist Church. And we have an exciting program for you today. We have Dr. Joseph Keith Melanson, who is the chief transplant surgeon for the GW Transplant Institute, and he's an esteemed professor of surgery. And also, we have Dr. Afsoon Roberts, who is associate professor and medicine and a program director of the Infectious Disease Fellowship at the George Washington University. Missing us today is normally Dr. Clive Callender from MOTEP, which is the Minority Organ Tissue and Transplant Education Program. And we're just going to have Dr. Afsoon Roberts go with us and show us about how this great presentation that she's going to share with COVID-19 vaccines and boosters. This is a relevant topic for this season and this time. So, Dr. Roberts, let's go. We're ready.
Well, thank you so much for inviting me again to speak to your audience. It's a privilege and I thank you. So, today I had done a presentation, more than a year ago, talking about these vaccines. So, what I hope to do today is sort of bring you up to date about what's new about them and review some of the new data for you. So, I just wanted to start by reviewing three important facts. So, what is the function of a booster, since we're talking about boosters in particular? Well, the function of a booster is basically to enhance or augment or restore the immune protection that was conveyed by the initial series of vaccines. So, when we get vaccinated, when we got our first two vaccines in the case of Moderna and Pfizer, or the J&J vaccine or single vaccine, after a while our immunity wanes. We know this well by measuring people's antibodies level after they've been taking these vaccines. And we see that even at 3 months, the antibody levels start to decline. So that is the purpose of the booster, is to restore that immune protection and augment our antibodies upon receipt of the booster. The other thing to tell you, which is really important, is that we know that people are best protected from severe COVID-19 illness when they stay up to date with their vaccine series, which in most cases involves a booster, even if it's a single booster. And we're going to talk a lot about the first and second booster during this talk. The last fact that I want to just start off with is that there are different recommendations for boosters for people with immune compromise. And we'll talk a lot more about what kind of illnesses constitute immune compromise. All right. So this is a little graphic showing us the effect of boosters. And the three arrows on top basically show the risks of symptomatic infection with COVID, meaning you have COVID and have some kind of symptom, be it mild symptoms such as runny nose or cough, to hospitalizations to death. And the bottom three arrows looks at the same risks, but this time when you've had a single booster. So as you all recall, that vaccine we've been getting was basically made for that initial COVID virus, right? The virus that came around March, April, May of 2020. And as time has passed, as you all know, that virus has changed and there are variants which have slightly different genetic makeup. So this particular data graphic is a graphic relating to the Omicron variant. So unfortunately, as you can see, after receiving just 2 doses of the vaccine, this reduces our risk of symptomatic infection with this Omicron variant only by about 25%. It reduces the risk of hospitalization by about 57% and death by 59%. However, if you were to get a single booster, and this data, of course, it's 2 doses because Moderna and Pfizer are 2 doses, but if you were to get an extra dose of the vaccines, it reduces the risk of having symptomatic infection by 50%, which I totally realize is not great. And that's why so many people who are boosted and vaccinated are still getting COVID. But if you see, it has a very impressive reduction in rate of getting severe disease that would lead to hospitalization or, God forbid, death, right? So it helps a lot in protecting against severe disease. So we're going to sort of talk a lot about this as we go. All right, I don't want to bore you, but I do want to just very briefly review the vaccines that we have and how they work. Again, I won't belabor the situation, I promise you, but I do want to sort of remind you of their mechanism of action. So as you know, we have 3 authorized vaccines. 2 of them are mRNA vaccines, the Pfizer and Moderna, and then we have the Johnson & Johnson, also called the Janssen vaccine. So with the mRNA vaccines, this is basically how they work. You all know now that the coronavirus is called coronavirus because of the crown that it has around it, this crown that we see with the spike protein on the surface of this virus. So the mRNA vaccines basically have instructions, blueprint or map, will you, of how our cells can make a portion of that spike protein. So they basically deliver that information, that map, that blueprint to our own cells. Once they get inside the cell gets rid of the mRNA, but it makes a portion of that spike protein, which it basically puts on its cell surface. And, you know, our bodies are just perfectly made. And so what happens with all of our immune systems is when it recognizes something different or foreign, it makes antibodies. And this constitutes our immune response to infection, but also immunization. So every time your body sees a new pathogen or you have a new infection, it forms antibodies. And it does the same thing when you get a vaccine. So that is basically the mRNA vaccines. The Johnson & Johnson vaccine basically does the same thing, except that instead of using an mRNA, it uses a different virus called an adenovirus. And so that adenovirus, which has been made not harmful or innocuous, provides those same instructions to our host cells for our body then to, again, make the same spike protein. So it's called a viral vector vaccine because another virus is basically conveying that information to our own cells. So once again, the cells make the spike protein, our immune system comes along and makes antibodies and confers immunity in the case of this vaccine to the COVID-19 infection, okay? And as I said, that adenovirus is made innocuous so that it can't cause adenovirus infection even though it's being introduced into the body, okay? So that's the mechanism of action of the vaccines that we have. So now let's talk about these boosters. I emphasize how important it is to get the boosters, just because although it's less likely these days to protect us against getting the infection in the first place, it does have about a 50% protection rate. It is very important to basically keep us from getting severe disease. All right, so who's eligible for a single booster? What about just getting one single booster? Well, pretty much everyone. So everyone 12 years and older can get a booster after completing their primary series. So for people who got the Pfizer or Moderna vaccine, they can get a booster. They have to wait at least 5 months or thereafter to get their third vaccine, which can either be a Moderna or a Pfizer. Those who received the J&J or Janssen vaccine, they can also get a booster as soon as 2 months after their initial vaccine. And in the case of the J&J vaccine, they're recommending that unless anybody has a particular concern about getting an mRNA vaccine, to actually change it up and go from the J&J to the Moderna and Pfizer vaccine. The reason for that, it seems to have the best augmentation, the best effect on our immune system and conferring immunity. And just to remind you, at this point in time, only the Pfizer vaccine booster is available for 12 to 17-year-olds. Okay, so everybody is eligible for booster number 1 and highly encouraged, based on the graphic I showed you, to get that first booster. In fact, you're not completely immunized unless you've had a booster at this point. So to being up to date means a single booster for 100% sure, okay? So who's eligible for a second booster. Now, this is much more nuanced, okay? And we're going to talk about a lot of factors to consider on whether or not a second booster should be given and who should get a second booster. So first, let's just talk about who's eligible, okay? Who's eligible to get that second booster? All right. Well, first of all, everyone over 50 is eligible. So if you wanted to have a second booster, you just go and get it. If you're over 50, there's basically that's the only indication. If you're younger than 50, anyone under 50 and over 12 who has moderate to severe immunocompromise, and in just a minute, I will tell you who's considered to be moderately to severely immunocompromised. But anyone over 12 who has some kind of immune compromise is eligible to get a second booster. And then thirdly, anyone who had 2 doses of the J&J vaccine, so one primary and one booster, again, the J&J booster, is also eligible to kind of change it up and get a booster with the mRNA vaccine. Again, the idea being an augmentation of the immune response. All right. So first of all, let's talk about who is considered moderately to severely immunocompromised, okay? So this is the list that's been put together by the CDC. I do want to remind you of something. These are all self-attested. So if you show up to get your vaccine, no one will ask for your records or, a letter from the doctor or anything like that. You just tell them that you have, an immune compromising condition. That's all you need to do. There's no need to bring any documentation with you when you're getting your fourth booster. But severe to moderate immunocompromise consists of folks, one, if you have active cancer on therapy, right? So you're getting chemotherapy at regular intervals. If you are an organ transplant recipient on medications that suppress the immune system as a way of preventing rejection of the transplanted organ. If you have not just HIV, but advanced or untreated HIV, so AIDS and untreated people on no medications with weak immune systems due to HIV. If you are a person who's on high dose steroids or any other agent, and I'll give you some examples. For example, people with psoriasis or people with rheumatoid arthritis, people with Crohn's disease, sometimes are on these medications that you might have even seen on TV, names like Humira, etc. These all suppress the immune system because those are all inflammatory conditions, and these medications are designed to suppress their immune response. So those folks all are eligible. There are also primary immunodeficiencies, conditions where people are born with that causes immunodeficiencies. They have these very fancy names like I've listed here for you. Those are very uncommon, but some people are born with these immunodeficiencies. And then lastly, folks who have had a stem cell transplant. These are usually people with some kind of blood cancer like leukemia. Those would be eligible. They sometimes have received what's called CAR T-cell therapy. CAR T-cell therapy is basically a treatment that is designed to help the immune system attach and kill cancer cells. So these are all, as you can imagine, pretty severe immunocompromising conditions. So all of these people, regardless of their age, should get a fourth booster for 100% sure. All right. So what are some other factors to consider if besides what we just talked about? So if you're eligible, other questions to ask yourself. So say you don't have any of these very severe immunocompromising conditions. Are you or someone you live with at risk of getting severe disease for other reasons? So for example, if you are a person with emphysema, right, you have lung disease, then it would stand to reason that, God forbid, if you get COVID, because it can affect the lungs, that you would have more severe disease, for example, right? And the reason why the recommendation is for you or someone you live with is because if you live with someone whose immune system is frail, you getting vaccinated basically reduces the chance of you taking COVID home to your loved one. So that is why that recommendation is there. So you're just kind of trying to form a bubble around them by protecting yourself. Obviously, we already talked about moderate to severe immunocompromise. Another other factors to consider about getting that second booster: are you someone who is constantly exposed? For example, would be, a teacher who is in a school with multitudes of kids who are young and don't keep the masks on and are constantly calling in with COVID infection. So that is another thing to consider. Are you living with someone who, for whatever reason, is unvaccinated? We know that unvaccinated people who've never had a single dose, are particularly vulnerable in terms of hospitalizations or death. So again, getting that fourth booster has the same bubble effect, trying not to bring the COVID home to someone who, for whatever reason, has not been vaccinated. And then lastly, how active is COVID in your community? This has been harder to tell, although I'm sure all of us in DC can attest to the fact that there is now high community levels. We used to be able um, to measure that much, much better because people would get tested in institutions and labs. The more we test at home, and it's a wonderful thing that we can test at home, but the more we test at home, the less likely that we know the exact numbers, of course, because people who get tested at home, there's no way of knowing that they're positive. Only if they take the time to go on the Department of Health website and declare that they're positive would they be added to the data or to the statistics. All right. So other still other factors. If you're eligible, can you wait and not get that fourth booster? And I'm going to give you some examples at the end of this vaccine, just so I have covered some scenarios that might help you decide. But if you have had a recent COVID infection within the last 3 months, you probably don't need that fourth booster because that native infection, you acquiring the disease, causes antibody protection in and of itself. Now, it's not as reliable as getting a vaccine because the amount of antibody you produce when you get infected with COVID has to do with how severe the infection is. So, for example, if you just get a runny nose or just a little tired, you probably don't have much by way of a robust antibody protection, right? And so, but still, for 3 months at least, it'll give you some leeway. So, if you've had the infection within the 3 months, you can wait for that fourth vaccine. The other thing, and I really want to emphasize this, is that consider waiting if getting a second booster now may make you not want to get one in the fall. Okay. Just because, this time of year, you would all agree that we're much more likely to be outside. And so we all know that being outside is protective against getting COVID infection. But in the fall and winter, we tend to be more indoors, and all respiratory viruses, influenza, RSV, all kinds of respiratory viruses are much more prevalent, of course. And so in the fall, it is quite probable that we're going to all get revaccinated again, or that's what the CDC is going to recommend. So if you're someone who says, gee, I don't want to get vaccine after vaccine, then, and I'm doing fine, then perhaps you should think about, holding off and getting a vaccine in the fall. The other thing I want to make sure I tell you, which is really important, is that currently there are studies that are being done to basically change the COVID vaccine. Remember, I told you the vaccine is against that very initial virus that came in early 2020. And now we, of course, have had all these mutations and variants. So what they're working on is just like the flu vaccine. You know how when you get the flu vaccine, it's called quadrivalent. It has like 4 different strains of flu in it. And the way it works, by the way, is that they look at the flu that is going around in the southern hemisphere during our summertime, because they have their winter time, and they see what flu variants are circulating there. And then they try to predict what's going to circulate here. And so they construct this vaccine every year for us to get. Oops. Now, sometimes, I'm sorry about that. Sometimes it's a good match and sometimes it's a bad match. The very same thing is true about the coronavirus. What they're studying is trying to see if they can put 2 different strains, bivalent vaccine for the fall. So, for example, they could put Omicron and say Delta, which caused such severe disease, in the fall of 2021. So I think that we're going to have vaccines that are a better match for what's circulating now. So I promised you some examples, and hopefully I'm not running over time. I know I was given 20 minutes, and I know I'm running. So if somebody wants to interrupt me at any time, I'm more than glad to stop. But some examples that I wanted to give you is just some to help you decide. So say you're over 50, right? And you have none of those immunocompromising conditions, and you're not a teacher, or none of those factors come into point. And you have, maybe you have just a eczema, but nothing, no chronic medical problems. Do you have to run out and get your fourth booster because you're 52? No, you don't have to. And that's why this is kind of nuanced. You can, you're certainly welcome to, but it's not this hard and fast, you better go get it right now. Okay. On the other hand, say you are 75 and say you have congestive heart failure, or you have diabetes, or say you have kidney disease on dialysis and you're 62, then that's something that you should consider getting this second booster as a way of boosting your antibody response. The reason why the CDC didn't make these hard and fast rules for the second booster, because as you can see, a lot of factors go into the second booster. Really, it's an individualized decision that you can sort of consider and also discuss with your physician if you're unsure. Okay, so let's keep going here. All right. I also wanted to, if I may, and again, interrupt me if I'm talking too long, is wanted to just update you on the vaccine safety data, because the first time that Reverend Curry invited me and Dr. Melanson invited me, we had just started giving out the vaccines and had limited data. Now we have a lot of data. So since I'm advocating for vaccines, I want to transparently also go over the safety data that we have to date. So first of all, right now we have, this is not, we always said, oh, this is new, not many people vaccinated. Now we have 576 million doses of this vaccine, okay, that's been administered. And this is data up to May the 2nd of this year. Okay, so lots and lots and lots of people have received doses of this vaccine. What are the common side effects? Exactly the same ones that we talked about now a year and some time ago. Local symptoms, pain, maybe redness or swelling at the site of infection, or systemic, I should say, and or systemic, because you can get both. When you get a fever or chills, muscle aches, feeling kind of achy and not great, headachy, maybe it's fatigued or nausea, those are still the most common side effects of the vaccine. What about serious side effects? What do we know now after some 570 million doses of the vaccine? So I have listed the severe side effects in the next two slides for you. So one is anaphylaxis, as a severe allergic reaction, which could manifest as hives, difficulty breathing, swelling of the tongue and lips, and low blood pressure. I do want to emphasize that anaphylaxis or a severe allergic reaction is something you can get with any vaccine. So that is something to just make sure it's not peculiar to the COVID vaccine. And this is something that's as old as vaccines have become available. It's rare. It's a 5 in 1 million chance that you would have anaphylaxis. And that's why people can't just get the vaccine and walk out into the street. They stay, and in case there's anything, so that people at the pharmacy or at the doctor's office, wherever the vaccine centers, can administer epinephrine and anything needed or transfer to the hospital. The second one is thrombosis and thrombocytopenia syndrome, which basically is a fancy way of saying you can get blood clots. So blood clots, as you know, is another thing that they've been looking at very carefully with this vaccine. It's a 4 in a million doses, so it's pretty rare. But there is a causal relationship with the J&J vaccine. When it happens is right after the vaccine, not like if you got it 2 years ago. But that is a side effect that we have seen and has been very much in the news. So now they know that its incidence rate is 4 cases per million. Guillain-Barré syndrome is a neurologic consequence which can happen with vaccines or viral infections themselves. Again, this is as old as any vaccine that we have had. It's not peculiar to COVID at all. Patients can have damage to the nerve cells, causing muscle weakness or even paralysis. Very rare, but it happens with all kinds of vaccines. Usually neurologists treat this by giving steroids and certain medications to reverse this. But this can also happen, as with all vaccines, with the COVID vaccines. And then the last severe reaction to talk about is this condition of myocarditis and pericarditis. One is inflammation of the heart muscle, and the other is inflammation of the outer lining of the heart. This is the blood clot and the Guillain-Barré was more seen with the J&J vaccine. This is more seen with the Pfizer Moderna vaccines. It, for whatever reason that is not understood, has a predilection for males and adolescent males, not 45-year-old males. This is all very young males. We don't know why. We have no idea why do they have a more robust inflammatory response with the vaccine. What happens? But you can see the rates there. So most common among 12 to 15-year-olds, about 347 reports in 25 million doses administered. So they're all rare, but there are things. Again, this is highly treatable. You would treat it with anti-inflammatories, things like Advil, whatnot, and it gets better. But those are in fact, there are side effects that are severe with these vaccines. So I wanted to. I was asked also to talk about Paxlovid. I think Dr. Callender particularly wanted to hear about Paxlovid, so I did prepare a couple of slides, but I don't know if at this juncture, Dr. Curry, if you wanted to ask me some questions, or did you want me to keep going?
Yeah, if you could move quickly, because we would like to get to the questions. We're a bit over time, but we need this information.
Okay,
So
so I
let's
don't
go with the other slide.
sure. I don't have to tell you about Paxlovid. This was like a Dr. Callender particular. So he wanted me to add this on. So I can stop now and we can do questions.
Just go ahead. Yeah,
All
let's
right.
go ahead. Dr. Roberts, you're muted. No, we can't hear you at this time. Something happened. Can you unmute? It's not. All right, Ellis, can you bring on Dr. Malansan? And we can continue. Dr. Malansan?
Yes. Can you hear me?
Okay, I can hear you.
Okay.
I know maybe we can have Dr. Roberts go out and then come back, but we may want to, the Paxlovid, did you want to make any quick comments with regarding that? And then we can go back and see if we can hear from Dr. Roberts.
Yeah. Well, first of all, I mean, what a fantastic presentation.
Absolutely.
And Dr. Roberts did a great job of updating us since we have so much more data. I remember the last time she spoke, it was just at the beginning of having the vaccine. And now that we have the vaccine, just what she talked about last time, which was predicting that it would be very safe, has come to pass. We've given millions and millions of dosages of these vaccines, and people have done very, very well. So, as the professionals have always said, this was the right thing to do, and it's undoubtedly saved hundreds of thousands, even millions of lives of Americans. We've lost over 1 million people because of this horrible infection. However, we've saved millions of lives with these vaccines. So I'm so impressed that she was able to give the real data and for people to understand what a difference it has made. The other thing that I like that she went into was why the booster is so very important, because I can tell you from working in the hospital, we have seen that although as of recently in the Washington, D.C. area, there has been an increase in infection as you get these new strains. We've not seen a huge increase in hospitalization, which was the original problem going back in 2020 when we had
Hmm.
so many people in the hospital. So although we are having many patients that still can get the infection, they're protected against getting very ill because of the vaccines, and in particular the boosters. So this is great information for our people to understand. When you start talking about the antibodies, and I hope we can get Dr. Roberts back to discuss this. But what I think the questions are from people and from patients that I interact with is the difference in the antibodies,
That's
because
right.
some of the antibodies you give when the person has an acute infection,
Infection.
and then some of the antibodies you give for prophylaxis to protect
Check.
in
Correct.
certain patient populations. So I would love for Dr. Roberts to go into that in detail, but I can just tell you, my patients, which would be in that category of the immunosuppressed patients, people that are taking medicines that affect their immune system. What we have seen is that we've been able to really decrease their infections, not only by making sure that they're vaccinated and boosted, but we make sure that when they're infected, that they get treated with the monoclonal antibodies. And we also have patients that are receiving the prophylaxis antibodies. And
So
these things are very protective for transplant patients.
so let me ask you, Dr. Malansai, until we get Dr. Roberts back.
Okay.
Then I've had 4 jabs, so to speak, right? I've had the Moderna, uh, been twice vaccinated, twice boosted, and will I eventually need another?
Well, that's a good question. That's one for I was going to ask Dr. Roberts, because I'm
Yeah,
in the same predicament as you, Dr. Curry. I've had 4 as well, and I did have a mild infection back in January.
hmm,
So the question becomes, do we need a 5th shot? And
that's right.
I think the answer is going to be, as long as we have high levels in our community, high levels of infection. You and I both deal with the public a lot. So, the 5th shot is probably going to be needed, as you go out 4 to 5 months from the last shot. Dr. Roberts was alluding to the fact that as the fall comes, we're going, when the infection rates start to go up again, because in the spring and summer we spend a lot of time outside, we spend a lot more time inside.
Yes.
um,
Yeah.
so
Yeah.
the community levels are going to
Right.
increase infectivity. So we're probably going to need even that 5th shot, even though I don't think you're over 50 yet, but you will need that shot though,
I,
Dr.
I I'm
Curry.
I'm proudly over 50. So I don't have a problem with that. Um, I'm not gonna
So
hide
am
my
I.
age. So yeah, I'm
So am I.
proudly over 50. But let's think about this. We're talking about people right now, and generally we're assuming that they've been vaccinated. I know some in my own community here in Washington, D.C., who understand that the vaccine was for the original virus. They sometimes believe some of the misinformation and disinformation. But one of the things that has come up in the discussion is that since they've had COVID, they feel that they are totally immune from the coronavirus and its variants. Since they've had, let's say, alpha, right?
Right. Yeah.
They don't need anything else. What
Right.
would you say to them?
Right, and that's just not accurate. And I can tell them, sadly, I've lost patients who have had prior COVID infections.
Absolutely.
Every time that virus mutates, it's a new threat to the immune system. And
That's
what
it.
we do know, and Dr. Roberts, of course, spoke to this, is that the immune responsiveness from the virus, I mean, from the vaccine, is much more robust. It's a stronger response. So even if you've had a an infection and then a response, even if you've gone and measured your antibodies, it's still not as good as the antibody you response you get from the vaccine. Now, we will tell people, if you've had an infection, then you can wait a while. You can wait a little bit before you get the next booster. That is true. But what you're describing are people that have never been vaccinated, that have had COVID. I know people that have had it a few times, and they, like you said, they think that now that they're untouchable. And that is not true. This virus is very different from other viruses. You're old enough to remember when we used to have the chicken pox parties.
Absolutely.
You'd put all the kids together, everybody gets chicken pox, and then that's it. You're done with chicken pox for the rest of your life. But not every virus is the same, right? So that's what I think some of the misnomers of people is that this virus is just going to be like other viruses where once you have an infection, you're done. That's not the case. And I think we have Dr. Roberts back. Are you back,
Dr. Roberts? You're back. We're so glad that you're
Mhm.
back. Welcome, welcome. Look,
this is, let me tell you, it takes a village to do this. Next time I'm coming to your house, Dr. Curry, and you have to just put this up for me, because otherwise this is just, I have like used up the entire facility in this transplant center of Dr. Melanson, everybody, all sorts of manners of people trying to help me. Okay, I can hear you, and I didn't touch anything, so I'm not exactly sure what happened, but here I am.
But we definitely need you. We've talked about, does having COVID provide immunity, and will we need a fifth vaccination? And if you provide any comments on that, that would be helpful. And before you do, I just wanted to tell those in the audience, feel free to drop your questions in the audience, in the chat, and we want to make sure that your questions get answered.
All right. So, yes, getting COVID does confer immunity. It's just that the antibodies are very much dependent on the severity of disease. So, if like my daughter had COVID a month ago, she didn't even bat an eye. The only reason she knew was that she had an exposure. She self-tested. I would imagine that if I were to check her antibodies, there just won't be very much robust antibody production because she really had a very mild disease. Who wants severe disease? But if you had severe disease, you probably have a more robust production of the antibody.
I see.
We know now that we can get COVID over and over and over and over and over and over again, sadly, right?
Like the flu, right?
Like the flu, exactly. So what the purpose of revaccinating people at regular intervals, and we will see how often we're going to need it. I know that we're going to need it in the fall, and then could it be that with these variant vaccines we have better match and better protection and more long lasting? That remains to be seen. But the best case scenario is we're probably going to have yearly vaccinations, right? That every year people say, oh, put this variant, and it very much like the flu. And I mean, Reverend Curry, if we can make this so that, sure, it's a nuisance to get a cold, but if you get a runny nose and you have like aches and pains, but then that's the extent of it, big whoop, right? We don't want to spread it, but that's where we're at right now. Okay, we're not going to make this go away. The best we can do is make it be a nuisance more that rather than having people, die or have to go to the hospital. A cold like all the other colds we've gotten all of our lives.
Yeah. So in the neighborhood where I am, I happen to be in Ward 7, DC, and I also think about Ward 8 and part of Ward 5 and other places in the city that have not been vaccinated as strongly, and I think about the comorbidities as well.
Yes.
And I'm a little concerned about comorbidities and all of the side effects that you're talking about, because, for example, Dr. Melanson can verify that, in zip code 219, which is over here east of the river, we have the highest incidences of kidney disease, not only in DC, but rival those across the nation.
Right.
So when we start to talk about, swelling in kidneys and swelling in hearts and all sorts of things like that. I'm concerned that the coronavirus is maybe a catalyst for even some worse advanced case illness. What do you think?
So anytime you have a devastating illness, sure, it will impact your chronic medical conditions, right? We know that. It's a strain, if you will, right?
Mhm.
So if your body is fighting off infection, your diabetes is out of whack. You'll see the sugar levels go up. Your high blood
Yes.
pressure is poorly controlled. So yes, every time we get a stressor, an infection that makes us ill, it impacts all of our systems. You're absolutely correct.
Yeah, yeah, yeah. That is so. Dr. Melanson, you look like you wanted to jump in right there.
Well, yeah, I was going to just agree with you, both the tenor of your question and the response from Dr. Roberts, because we have patients who are percolating along at stage 3, 4 kidney disease, and then got COVID, and COVID threw them into stage 5, and having to be on dialysis. We've also seen some very strange vascular problems with some of these patients post COVID, including aneurysms and
Yeah,
things of that nature.
yeah,
So it really is can be a devastating infection. And what happens is, unfortunately, is that people know others that have had COVID, and they weren't that sick. Dr. Roberts was speaking about her daughter. I had an infection in January. It was very mild, of course, post vaccination. But the point
Yeah.
is, that it's not going to be like that for everyone. And
right.
some people that are healthy, can get very, very ill, even to the point of death, if they're not vaccinated and they get this infection. This is a real serious infection, and it continues to be an issue, even though as a community, the fact that we have so much vaccination in this area, that's very good. But we still, on occasion, see some very, very severe illnesses. And I just had unfortunately, I had a patient of mine who was vaccinated just die of
Yeah,
COVID infection.
yeah.
And so people are still dying, and this is still very, very serious.
And that's something we're going to have to continue to make sure that we sound the trumpet loud and let folk know you still need to be vaccinated.
Yes.
Um, I want to jump to one question, and it's surrounding a comment that's been made by Mecca in the chat, and she said initially I had a severe case um, and was hospitalized, and however, all the second case of COVID, it presented like a normal cold. The virus is very strange because I do suffer from long-term after effects such as neuropathy. That is a great thing. Can you speak to this whole piece of long COVID?
Yeah.
Because we're seeing it in children, we're seeing
Mhm.
it in other adults. It's impacting learning, it's impacting functioning on the job and in other um, occupations. And so, tell us a little bit about this long COVID and what we can
Sure.
do.
Sure. So unfortunately, a very challenging problem, as you well stated, Reverend Curry. So it's we have very little insight as to why this happens. As you know, there was a recent statement by the NIH after studying people with long COVID. They still haven't. Doesn't mean they're not suffering and don't have symptoms, but they haven't been able to find anything that has gone awry despite multiple tests to see why are some people going on to have months and months of completely different symptoms. Some people suffer from fatigue long term. Some people suffer from changes in taste and smell for over 2 years. Some people have neurologic problems. Some people have issues with their respiratory function. So it seems that it's something that's definitely very concerning and happening, but it's been extremely puzzling to researchers trying to figure out what about the virus or what about the host or the person infected makes one person prone to it and for as long as for the duration. A really puzzling phenomenon that we really haven't seen with other viruses. So we have a
Mm.
lot to learn, and so far, unfortunately, no light has been shed as to why this is happening.
So I wonder, as this virus and as we move from pandemic and to an endemic situation, and you might explain the difference between the two, the more endemic that this whole virus piece becomes, is it that we have some side effects and unintended consequences that we will have to learn to live with and begin to learn to treat? Is that what you're saying?
No, what I'm saying is that unfortunately, so most of the cases of long COVID, interestingly, were also um, it seemed to be more common in some of our earlier variants with the more severe
Okay.
disease. At least with this Omicron, there's still long COVID, but not to the same degree. It seems to be a milder disease to begin with. What I'm saying, which is really fascinating for researchers and scientists, is that no one really knows why people get long COVID and what is wrong with them. Like one theory is, are they somehow inflamed? Did the COVID vaccine, or I'm sorry, the COVID infection cause some kind of inflammation? And that's what it is. But when they look at people's inflammatory levels, very sort of fancy tests looking at different markers of inflammation, they see no difference in folks who have COVID with long term symptoms and people who are completely recovered. So it's an interesting phenomenon that we know very little about, and such an unfortunate thing, of course, for those who suffer, because there's no good therapy for it, as you well know.
Yeah. Could you explain the difference? And I use the terminology, but I'm gonna ask you to give us
Sure, sure.
a definition
Pandemic. Sure.
of pandemic versus endemic. I
Yeah.
think that's
So
very
exactly.
necessary.
Exactly. So the goal of it, the endemic, you should think of it as a good thing in many ways. We would like not to have it at all, but since that we don't get to choose that, we'll take endemic. Think of it. You see how now you have these huge waves of infection that go across the world, right? This, if you look at a graph, there's this very steep, you know, uh, 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 curve up of all these cases and then a slow decline. What, being something endemic is, it's always there. It doesn't go away, but it doesn't have these huge waves anymore. And those waves are what overwhelms the hospital system, the medical systems, the therapies we need. So if we're supposed to live with this, endemic would be something where there's these slow level, very, very small waves, but not a whole lot of people infected at the same time, basically.
Okay. Dr. Melanson, what are your thoughts around long COVID and things being moving from pandemic to endemic?
Yeah, I'm agreeing again with Dr. Roberts. I have patients who have long COVID. I mean, I have a lady that has had no sense of smell for over a year.
Wow.
And there is no rhyme or reason. Even I alluded to these vascular issues that we see in some patients. And again, just like she said, we have not been able to figure out who are at risk of these weird sort of manifestations. I mean, the normal kind of stuff from COVID, we understand. We have a good understanding of why that happens. But who goes on to have certain types of organ derangements? We this is important to us in transplant because people will die of COVID, and then we want to use their organs for transplant, and we have been successfully doing that. But there are patients that go on to have dysfunctions of their organs because of the COVID as well, and there's no rhyme or reason as to why this is. Now, I think over time, because this is such a new virus, and all of the areas of research is just new as well. Maybe we will have a better understanding in the future, but right now we don't. And like Dr. Roberts said, it's so different from these other viruses. I mean, man has been dealing with virus infections forever, but we've never seen something that has had such a myriad of impacts on the body, and without any rhyme or reason. Because, like she said, the typical sorts of inflammatory markers are not seen in these patients, even when they have symptoms. Dr. Roberts, when you were gone there for a second, I had a question. I wanted to try to understand the difference between the antibodies that we give when patients are acutely ill, trying to help them get over the infection, and the antibodies we give for prophylaxis. Can you explain to that what's the difference?
I see. So I see what you mean. So just to clarify for the audience, so there are monoclonal antibodies that are available to be given to patients who are infected with COVID and have a high risk of progressing to severe disease. So say you're an organ transplant patient and now you've acquired COVID and you're at risk for having severe disease. You can go to an emergency room like our emergency room and get a monoclonal antibody, again, conveying immunity to you in a way so that you can fight off the infection, right? Because we know sometimes that people with certain conditions like multiple myeloma or even folks who are on these medications that suppress the immune system, sometimes they don't have as good robust antibody production after a vaccine as a person who is healthy and is not on immunosuppressive therapy. So this is a way of sort of conveying the immunity. So, for example, there's the drug right now is called bebtelovimab. I can hardly say it myself, but I've had a lot of practice. So, for example, you can do that. So there's 10 million monoclonal antibodies out there. They've all been studied in different ways for the COVID, as you know, and some of them have been shown to have some efficacy in preventing progression of someone who already has it to getting severe disease. As you know, there's also a drug called Evusheld, Dr. Melanson, which is completely prevent. This is not like bebtelovimab, which is given to someone who already has it. Evusheld is given to someone who, again, will have trouble mounting an antibody response to a classic vaccine, and this is given as a way of providing some protection by the way of monoclonal antibodies to someone who's not infected. So anybody in the community, for example, who has immunocompromised, even if they got their vaccines, but they have multiple myeloma or transplant patients or chemotherapy patients, are eligible for getting these preventive monoclonal antibodies as well. And then lastly, Dr. Melanson, I think you meant there are other monoclonals that are used for treatment when someone is severely infected, like tocilizumab, and those are not used as broad as much as they were initially in 2020. They're not as popular anymore. But yes, those monoclonal antibodies also exist. They're all like working as a way of providing immunity, anti-inflammatory, etc.
Sure.
Wow. Well, Dr. Roberts, I wanted to ask if you could, for our audience, if you had any closing words to say, how would you encourage our audience, very strongly, I might add, to adhere to what you've shared in your presentation today?
Right. So I cannot emphasize enough the importance of getting your complete set of vaccinations. Okay. For everyone, this includes at least one booster. Everyone. You're not really considered having your full set of vaccines until you have had at least one booster. Okay. And then the most important is that if any of those conditions that I went over, Dr. Melanson went over, whether you have immune compromise for a variety of reasons, whether it's those classic ones we talked about, or whether it's kidney disease, heart disease, diabetes, etc., then consider that second booster. And I'm more than glad if you want to share my slides somehow, post them somewhere, because it gives them the criteria and they can always refer to it. And again, keep your eyes open for these new vaccines coming, which may be a better match to the variants that we have. The data is being reviewed, I believe, in a month or so. So we're very hopeful that we would have better vaccines to vaccinate people with in the fall.
Well, I have another takeaway. It's just we need to get your slides and be informed. Not
Yeah.
only do we need to be vaccinated and boosted, but we definitely need to be informed. Dr. Melanson, anything from you before we close out?
Well, first of all, I just want to thank Dr. Roberts for
Excellent.
being here again and updating us. And this is the way you really try to fight against the misinformation that's all over the internet. And people still are saying all sorts of fallacies about how the vaccine kills. And she was very honest, and she went through how there are possible side effects, including anaphylaxis. And I actually know someone that did have a Guillain-Barré sort of
Mm.
reaction, as rare as it can be. These are honest side effects that can happen from vaccination, but they are exceedingly rare. Most people will, if they have any sort of side effect, would just be a local sort of inflammation where the shot was given, or even like a joint issue. So it's very, very safe. Dr. Roberts did a great job of explaining that, and I thank her for her service, because this is a service. Because every time we convince someone who was a vaccine denier to finally get vaccinated, it saves lives. I've seen this. We get frustrated in dealing with people that just don't want to listen. But on and on, we are seeing in my own practice, I'm seeing people that have relented and are now getting vaccinated. So we got to keep up the fight. We got to keep chipping away at this rock of ignorance in order to get people to do the right thing. And thank you again, Dr. Roberts.
My
Yes,
pleasure.
thank you. Thank you.
Thank
Thank
you
you
so
so much.
much.
We just enjoyed you as always, especially with providing us with the updates. And I'm just glad that at least so over 500 and some odd million doses have been given. And we need to, that's something to be excited about. Thank you, Dr. Roberts, for your information. Thank you, as always, Dr. Joseph Melanson, for being with us today. These are the Kidney Talks with the George and Ron and Joy Paul Institute at the George Washington University. And we're excited today because we've had some great discussion with the experts, Dr. Roberts and Dr. Melanson. Thank you so very much, those of you in the audience, for joining us. And we ask that you always look for us, because we're going to give you relevant information that you need, that will help you as you live your lives and live your best life at that. So take care, be well, love you,
Have a
and
nice